Good evening. Welcome to our summer series on EdgePRO. We're going to get started here in about 2 minutes, just making sure that we have time for everybody to join the program. We thank you for joining. Well, good. Looks like we've got a quorum. Why don't we go ahead and get started? I'd like to go ahead and introduce our program for this evening. My name is Chris Rabbit, the Vice President General Manager here at EdgeEndo, and we really thank you for joining our first program, what is billed as a summer series on EdgePRO, discussing advanced cleaning and disinfection along with other practical outcomes in applications in laser-assisted endodontics. Tonight is going to be our first event, if you will, and we will build into 2 more events. This is ideally suited, we find, for both existing users of EdgePRO technology, as well as folks that are interested in the technology and learning more. So our content will build over these next 3 programs. I'll go ahead and introduce our speaker here in just a couple minutes, but then, of course, we'll evolve to a panel discussion on August 17th, and then another panel discussion for case review on September the 14th. So we're hopeful that many of you have joined this evening, and you'll stick around and enjoy the entire series as we build out through the end of the summer. Hope everyone's having a great summer, and again, thank you for joining us. Tonight, we're going to kick off with how to achieve the ease of outcome in laser-assisted endodontics with EdgePRO. Many of you of the existing users on tonight's program have already started their experience with the technology, are learning a lot, of course. Just 1 second here. And, we want to use this forum and this opportunity to get your questions, answered, not only from your peers, but others that, may also be asking questions that have been on your mind. So please, 1 bit of housekeeping, there is a button on the bottom of your screen that is for questions. Please go ahead and click that if you have a question, and type that question, and I will curate those questions and make sure that they are answered at the end of our presentation this evening. Our first presentation tonight will be delivered by Dr. Charles Maupin. I want to give a brief introduction of Dr. Maupin. He'll speak for about 45 minutes, and then, as I said, we'll have some time for questions at the end of our event this evening. So really appreciate Dr. Maupin being here. Dr. Maupin was a doctor of dental surgery degree from Baylor College of Dentistry. Following graduation, he attended UCLA, and where he served as chief resident and received his endodontic specialty certification. He continues connection to UCLA, serving as a part-time faculty member to this day. And Dr. Maupin is a diplomat of the American Board of Endodontics. He's an active member of the AAE, the American Dental Association, Texas Dental Association, South Plains District Dental Society. He's also founding member of the International Academy of Endodontics, and he's excited to be on the forefront of minimally invasive endodontics. Dr. Maupin has a private practice, many of you might know, in Lubbock, Texas, and has really been a key contributor to the field of minimally invasive endodontics, as well as in the emerging field of advanced cleaning and disinfection, utilizing technologies specifically in the field of laser dentistry. Dr. Maupin tonight is here to kick off kind of an introduction to YSGG, erbium chromium YSGG 2780 nanometer wavelength, talk a little bit about his initial experience, and of course, as we build in this series, we'll get have more in-depth conversation on mastering technique and extending applications in this growing field. But without further ado, I'd like to pass it over to Dr. Maupin. We appreciate you being here with us this evening. Thank you so much.
Absolutely. Thanks, Chris, for the introduction. I'd like to echo what Chris said. I hope everyone's had a great week. Thank you for taking the time to tune in here. And I know most of you have probably had a long week, like myself. I finished up my last case about 2 hours ago. Pretty busy week, but I can honestly say, without the EdgePRO, I probably would have fallen off task, but the EdgePRO really helps me to stay on task, to deliver consistent results. And so I hope to share some of that with you. You know, we've got a short amount of time here today, but hopefully I can share a little bit about that. I've been using the laser since 2018. And, you know, when I first used it, to be honest, I was skeptical, like a lot of people. But, you know, after kind of making myself sit down, do some benchtop work, and then just employing it every single case, every day, I can honestly say it's something that I wouldn't want to practice without right now. So, you know, we'll kind of go through this. Like Chris said, if you have any questions, you know, be sure and put those in, and I'll do what I can to kind of answer them as we go. Okay, so many of you are probably familiar with this. Move this off my slide so I can see this circle here. What this is called is, it's called the golden circle. This was made popular by Simon Sinek. So if you've read the book Start With Why, you're probably familiar with this. And he uses this circle to describe why some people are successful, or, you know, more successful, and others are not. And you may be thinking, you know, well, what's this have to do with the laser? Just kind of show me what buttons to push and put it in, and I'm good to go with that. But I think if you kind of let me explain this a little bit, it'll all kind of start to make sense. Then we can look at some cases here at the end. But let's start with kind of seeing how Sinek breaks this down. You know, first thing he starts with is what. And if we you know, basically break that down is what do endodontists do? What do we do? Well, that's pretty simple. You know, we do root canals. And if we break that down just a little further, our what would be that we diagnose and alleviate tooth pain by removing the dental pulp and preventing apical periodontitis, and or removing necrotic debris, bacterial byproducts to heal AP. And so that would kind of be the what of what it is that we do. The how do we do that? That's pretty simple, right? Endodontic triad: clean, shape, pack. So we're all familiar with the how of what we do. The why. Now, the why is important. You know, as we incorporate new technology, it's easy to focus on the what. I do root canals, so therefore I need a laser. Sometimes we may dive a little deeper into it and say, hey, I do root canals. I'd like to clean better, therefore I need a laser. But if we focus on the why, which is our purpose, our cause, or our belief, the first two are going to fall into place. And once you understand that, then you're going to be on the path to achieving this ease of outcome, you know, in a relatively short, efficient manner with the EdgePRO. So if we think about this, what Sinek does is he gives an example from the outside in and the inside out. And so if we think about from the outside in, the thought would be that, you know, are going from what, how to why. It would be that I do root canals and need to clean inside the tooth, so I should incorporate the EdgePRO. Now that, you know, it's not too appealing, it's not too exciting. You're just kind of going through the motions, so to speak. And that type of mindset, it's really not setting you up for success. But if we flip it and we go from the inside out of how he talks about successful people think and innovate, and we reverse that, you're going to think, I want to provide my patients with the best possible care and need to further enhance the level of disinfection, of cleaning that I'm being done, so I should incorporate the EdgePRO. And we can see the difference between those two, how that second one is really going to set you up for faster and smoother adoption of the technology. So if we make a list of our why and, you know, list those out for incorporating the EdgePRO, I think we could, you know, at the very top, it would be we want to elevate the level of care provided. And then some subheadings under those, we want to increase efficiency. Why do we want to incorporate? We want to increase efficiency. And we'll see why that's kind of important here in a little bit. Obviously, we want to reduce the level of post-op discomfort that we're providing to our patients. We want to transition to a single visit treatment while not compromising on the cleaning. And again, we're going to look at a few things of what patients think about single visit versus 2-visit treatment. We want to become more conservative. I think everyone's trying to go that route now. Increase predictability. That predictability is everything from, you know, the instrumentation all the way through obturation. Increased outcomes. Now, I'm not aware of any studies that are showing any, you know, difference on the outcomes on enhanced irrigation versus traditional right now. But I think when you use it and incorporate it, it's just, you kind of get that clinician intuition that, hey, I'm definitely doing a better job here and better service for the patient. So we talked about, increased efficiency, 1 visit versus 2 visit. And this was a questionnaire that was sent out, and it was patient preferences regarding 1 visit versus 2 visit root canal therapy. And what they reported was that given equal success rates, 78% preferred 1 visit root canal therapy. 7%, they probably didn't understand the question and chose 2 visit would be my guess. And then 16% said they follow the dentist recommendations. And what they concluded was that although most respondents preferred 1 visit, regardless of the success rates, many would prefer 2 visit if the success rates were greater going that route. And so I think there are times, I've transitioned from a 2 visit practice to single visit. I am not entirely single visit. And a lot of times, again, it's that clinician, that experience, that clinician intuition. Hey, you know what? I did incorporate everything in here, but I want to give this one some chance to heal, make it easy for me to go back in if need be. And so sometimes we still do 2 visit treatment there. This paper here was put out by Dentsply Sirona Dental, and what they were talking about was a CEREC. And again, it was a little questionnaire. And what they found was that this was in Germany. Almost 2/3 patients were prepared to travel much further for treatment in 1 visit, and a greater percentage, 66%, would be willing to change dentist for single visit treatment. And I think this became readily apparent to us, starting in 2020 during COVID, with the amount of patients that they didn't want to come back in the offices. They wanted 1 visit treatment and to be kind of in and out type of procedure. And so we're seeing stuff that validates that patient's wishes there. How about flare-ups after endodontic treatment? This was meta-analysis of flare-ups. Flare-up frequency was about 8.4%, so not really high, but a decent amount there, higher than I want mine to be. Infection was considered the most significant factor. So we kind of know post-op pain, infection, greater chance of flare-up afterwards. And then what they also stated was that pushing debris apically can exacerbate infection or flare-up. And so we know that if you access the tooth and if you immediately start instrumentation after access, then you're going to be transporting debris apically. And so that's where incorporating the laser, as I'll show here later, can help to remove some of that coronal debris, tissue, microbial biofilm from the coronal portion, so we're not pushing it apically as we instrument. Conservative treatment. This was by John Cottamy and David Clark, and I think this was about 2010. And everything is now shifting from this endocentric, mindset to a restoratively driven endodontic treatment. So now that we understand the importance of conservative endodontics, and we have the technology, some of this wasn't possible without heat-treated files. Not possible, I think, without the advent, the introduction of enhanced irrigation into this. We simply couldn't do some of this stuff. We may have been kind of wishful thinking on some of it, but now with everything that's possible, we're able to transition from this endodontic centric mindset to this restoratively driven endo treatment. Now I want to switch here for a few minutes. I know this isn't directly on the laser, but at the AAE this past year, I gave a topic. It was on instrumentation and irrigation. And, with the introduction of advanced irrigation, there's been a big shift towards, either no instrumentation or very minimal instrumentation. And what I've titled this is traditionally we've had what I call the Schilder instrumentation technique, and now we have this minimal instrumentation. There's kind of this argument back and forth, and I call it the dichotomy of instrumentation. Dichotomy is simply a contrast between two things or ideas. And so again, this first part of this dichotomy is the Schilder mechanical objectives, and everyone's familiar with that. It's developing the continuously tapering cone, decreasing at every section as you get apically. You want flow in the case. Apical framing remains in the original position. Apical framing is kept as small as practical. And what this does is we have the elimination bacteria, bacterial byproducts, and pulpal tissue to allow for a 3D obturation. That was the whole goal of the Schilder technique, is you wanted to achieve all this for 3D obturation. And so what we saw, if you paid attention to Schilder recalls over the years or cases, shape out to an F3, F2, F3, is we follow these cases, and at least for me in my practice, what I saw is pretty quick healing initially, but you follow these cases at 3 years, 5 years, 10, 15 years down the road, they come back with these vertical root fractures that we see there. And so healed quickly. So the dichotomy, the Schilder technique, access is enlarged, mechanical objectives are followed. So if you do all this stuff, then you get quick healing. But again, what we saw later on is cracked teeth. And so that's why we have this transition to, the endodontically driven restorative treatment. And so what I moved on to was this dichotomy of instrumentation, the minimally invasive approach. And the minimally invasive approach addresses the pulpal and periapical pathosis by preserving coronal, pericervical, and radicular tooth structure here. The focus is more on the biomechanical properties of the tooth rather than the microbial issues here. And it utilizes restoratively driven access and shaping principles. So we've got this caries leveraged, some terminology. We've got the restorative leveraged accesses. It minimizes mechanical instrumentation. Passive irrigation techniques are challenged, and that's been reported in the literature. And I think everyone can speak to that as well. I know I can when I started early on. You have that IP case that comes back. You treat it very minimally invasive, tap on it, still hurts to bite on it. And so that was a problem with the minimally invasive technique. And so the goal here is maximum preservation of tooth structure. With this technique here, tooth structure is maximized, biomechanical strength is retained or not further weakened, irrigation compromised. So I wouldn't say no cracked teeth, maybe less cracked teeth, but the healing is slow, or maybe it fails to resolve where you have that continued pain on biting or percussion sensitivity. So that's kind of the dichotomy. And if we summarize that between the two here, we've got the Schilder technique, straight line access, tapering, benefits both the mechanical debridement and irrigation, greater susceptibility to fracture. And the minimally invasive technique focuses on conservation of tooth structure, minimizes the biomechanical strength, benefits it results in, nothing we do makes a tooth stronger, but maybe less weak should be a better term there. And the instrumentation, traditional irrigation is compromised. Higher incidence of non-healing findings. I think everyone can probably attest to that. And so what I recommend, I've been on both sides of it, and I can tell you in my practice where I've done non-instrumentation technique. I've done the F2, F3. I'm kind of meeting in the middle here now, and coming somewhere in the middle here in combination with conservation, advanced irrigation. We're meeting here in the middle, what we call RFA, or root form appropriate shaping here. And what root form appropriate instrumentation? It's instrumentation tailored to each root and further to each canal here. There's not a one size fits all approach. Hey, just use this one file, 1504, and do that here. And I think that's also the beauty where the Edge fits in, is it's not a one size, hey, it's not a cookbook, you have to do it this way. You are in control. Same with the instrumentation, same with that here. So as you can see, this number 31, it's got several multiplanar curvatures going on, additional 90-degree curves at the end here. Using a large rotary file here with continuously tapering file is going to be very detrimental to this tooth. File breakage, strip perforation, any of that going on here. So minimal instrumentation, active irrigation going on. And this is the follow-up here showing complete osseous healing here. CT on the left, pre-op, and healing on the right. And again, you can see the lingual plate was completely eroded or gone. Image on the left, image on the right shows complete osseous regeneration going on there. So with root form appropriate instrumentation and the active irrigation, we're able to achieve these techniques here. So dentistry, as everyone knows, I think everyone that got into it, it's a blending of science and art. It really is. And we need to respect the science while also blend in the art of the procedure. And so when we combine the technology of, in this case, the EdgePRO with root form appropriate instrumentation, then we're blending science with art. And the EdgePRO, it's the result of science. A lot of people, smart people got together, designed the tech, came up with the technology, went through the steps for that to make it available to us. And so it's important to understand the science of it, how it works, the power settings, the parameters, when to use what tip and where, what to have the power when you're inside the canal versus in the access. It's really important to understand all that. And so the EdgePRO, it helps on the scientific side to reduce the microbial load inside the tooth. While the root form appropriate instrumentation, it's going to take us to the artistic side of it and beyond the conservation of that. So I think that's why, why I went into dentistry is I like that scientific, but I also enjoyed, working with my hands. And so it's a beautiful blend melding of the two that we're able to do here in dentistry. And so many of you probably are already using the EdgePRO, and for those of you who aren't, just understand it's an open system that it's allowing the doctor, you are in control throughout the entire procedure. It works by cavitational streaming, so fluid dynamics through cavitational streaming going on there. It can be used, it's multi-cannular or uni-cannular. What I mean by that is you can disinfect all the canals at one time, or if you want to really focus on one particular area, and over the next 3 sessions, we're going to kind of discuss, hey, when we want to focus on one versus staying in the chamber more. But if you want to focus on one and put more power down the canal, the EdgePRO is the YSGG line. EdgePRO is the only laser that has the ability to stay in the access or go down inside the canal systems with their patented radial firing 200 micron. So it's a 200 micron tip that we go down in the canals, and then we have up to a 500 micron that we stay in the chamber. So we've got a 200, a 300, and a 500, but like I said, it's the only one that you're able to go down inside the canals and irradiate, activate irrigation down inside the canals. I mean, we know that that's where the most complex anatomy is. The beauty of it is you can use it at any stage during treatment, and I actually recommend using it not at the very end after everything's done, from the very get-go. After access, you should be using it. After instrumentation, you should be employing it, and then as a final disinfection, you should be using it. So it's used throughout, and it's real easy to just toggle back and forth between the two. There's no platform staging disruption of the clinical flow. That's another beauty of it. It's just grab and go. There's a little bit of capital investment. Everyone's aware of that. I think they've done a great job of basically keeping this, very affordable. For what this thing is, it's awesome. It's a workhorse in my practice. I love using it. Minimal per use fee. There's a little per use fee for the little fibers that go on the handpiece. So my guidelines, again, these are kind of my guidelines, are to incorporate the EdgePRO as early as possible in the procedure. And what this does is, as we talked about earlier, it aids with removal of the organic debris. So you're not going to be pushing that debris, transporting it apically as you instrument. So hopefully you've removed that out. I'm going to show you a little video here that I think shows a pretty good little example of that later. It facilitates instrumentation when you use it early. That's, we've in the past, we've had some devices, Endovac, there's some other ones out right now, and the endoactivator type of stuff. And with those, they may do a good job, but they only do it at the very end. And so it does not help with instrumentation. And that's part of the beauty of the laser, is it makes it more efficient by removing some of those obstacles early on, pulp stones, calcifications, removing some of that tissue up top. And so you're instrumenting the case quicker, 30% quicker. Just kind of pulling that number from my experience with it. And like I said, these passive irrigation devices may do a good job, but you're opening to a 35. And again, it's used only at the very end. Helps to minimize transportation of debris apically. We've talked about that ad nauseum. But you want to utilize the EdgePRO in between file usage, and this prevents inorganic debris accumulation in isthmuses, fins, tubules, and those who've seen my lecture before have seen evidence of that in the cases there. Guidelines going on here. Tips number 2 and 3. So the tip number 2 is a 300 micron tip, and the tip number 3 is a 500 micron tip. The tip number 2 comes in, I believe, 17 and 21 millimeter lengths, and the 3 is a 10 millimeter length. And I use these in the chamber only. The 3 for sure in the chamber only. The 2, some people will use down inside the canals. I never use this one inside the canals. I think it's too big to go inside the canals. And if you are using it, this is again where you have to pay attention to the power settings that you have. There's a calibration factor that goes with the tip 1, the tip 2, and the tip 3. You need to get with, if you have it, you need to understand this, get with your rep and learn this calibration coefficient, because the amount of power that you have on the screen that comes out of tip number 1 is not the same as the amount of power that on the screen of the laser that comes out of tip 2 and tip 3. There's about a 55% reduction on 1, 15% on 2, and then 3 is about a equivalent. So it's important to know that coefficient factors going on there. Used with solutions or water only. Tip number 1. Now I personally take, some people will say that you can take this to working length -1. I take this to mid-root only for, majority of my cases. Anytime I have solutions in the canal, EDTA, sodium hypochlorite, I'm going mid-root only with this, and at the prescribed settings here. I'm not changing the power or anything on that. A lot of research has been done on that for what power is safe to use, and so I'm sticking with that. Used with solutions or water only. About the only time I'll go to full length, I'll be using water only, and if it's an open apex tooth or something, it's a lateral incisor with a large apical abscess present and it's just failing to heal, and I want to get out there and kind of disrupt that, then I may put a 25mm length number tip on, go out the very end of it and activate it out the very end with water only. For lower, particularly for lower anterior teeth or any teeth that have a small access, very narrow canals, you want to adjust the wattage down. So typically we're going at 1.25 watts and 50 hertz. And for these small anterior teeth, my guideline is I'll go down to 0.75, anywhere from 0.75 to 1 watt and 50 hertz. And it's real important. So these small ones, if you see the solution really popping out of the canal and nothing in there, drop it down. Make sure you always have some type of solution water inside the canal at all times. This is my vital tooth protocol. I'm going to instrument most cases to a 1704 prior to introduction of the EdgePRO. And after I have a 10 hand follow length and that 1704 to work to length or somewhere near the end, I may be 2 or 3 millimeters. Maybe there's a lot of complex anatomy going on. That's fine. I'll instrument to the end or to that point, and then I'll stop and I'll go through the protocol here: coronal conditioning using hypochlorite on 50 hertz. Number 3, that's staying in the chamber only, and then I'll go through and do the canal disinfection. I'll open the canals up as needed. Typically, I'm doing anywhere from a 1704 to a 20. A lot of my cases now 2004, 2006 with a maximum flute diameter on any of those, and single canals 20 to 3006. Large single canals, single distals, anterior or something like that. Large premolar, finishing around there. Necrotic protocol. So this is where as soon as I access into the case on a necrotic case, I'm doing the coronal conditioning. Now you can do it with, as we go back, you can come and do this one right here. If you want to just start off with a hypochlorite, that's completely fine. Or you can do this 2 watts, 20 hertz, water at 90% and air off. Or you can have the air on slightly, maybe 5% or so, 5 to 10%. Just make sure you have a lot of water flow in there. And do this for about a minute. And again, that's really going to flush everything out inside the case there. And then you're going to instrument the canals. Small canals, again, 17 to 2004, medium large 2006, and to 3006 canal disinfection. We're going in with the number 1, 0.75 to 1.25, fiber to mid-root only. And you can do this 1 of 2 ways, and I'll show here. Assistant can fill with chamber with solutions, or I'll fill it and then activate it, and we'll pass the syringe kind of back and forth, such as on narrow anterior teeth. I don't want her, getting that syringe lure locked into the access and continuing to express hypochlorite. So I'll just fill it and then activate, and we'll go back and forth there. Large molars or something, large access, then I just have her constantly keep it full. And then we'll do a final rinse going on there. Okay, so what I did here, I've shown cases over the years, you know, that I can go through and find. But what I wanted to do is I just picked cases from this week. In fact, several of them are from today that I, you know, again, I finished about 5:30 and threw a couple cases in. Most of them either from yesterday or today on these. And I just wanted to show, hey, you know, it's kind of the bread and butter. I'm in the trenches, same as everyone else. And, you know, not every case is going to come out textbook, but I think these are all very consistent cases. And I can tell you the patient, you know, their post-op discomfort, this one reported back. I treated this yesterday, reported back today. She's doing great. I saw her as a consultation early in the morning. She was in quite a bit of pain. So she came in at the end of the day, and treatment time was roughly 45 minutes for this case here. And the treatment sequence was access, tip number 3 for water, with water only for 1 minute, and then a 1504 passive instrumentation to kind of maybe the mid apical third. And then I determined working length. And once I got working length, then I instrumented with the 1704 to length. And then I did the laser, and then I did a 2006 on the mesials, and it was a 3006 on the distal canal. And then we did a final disinfection with tip 1, final rinse with water, dried and obturate. And you can see we got a little apical anatomy going on there, just very consistent result here. This case was setting sealer here, so to speak, and tooth number 2. And let's jump to the CT real quick here, and then we'll go back to that. But what we have here on the CT, we got the DB, had a large MB2 and the palatal here. And I troughed and was not able to locate an MB1 on this case. I would have got as, you know, comfortable as I could, kind of going deep in there, didn't want to create any other problems. And so what I did, you know, we just activated with the laser, spent a lot of time. I went through the necrotic protocol in there, and then we obturated the case. And what we see here is this is the palatal, this is the DB, this is the MB2, and we retrofilled the MB1 canal here, just all due to active irrigation going on there. So again, you can see where I was kind of troughing down in there. Didn't have any maps. It was, you can see how calcified it is here on the pre-op, just completely obliterated over there. And so a lot of times on these, I'm not going to continue to trough cases and do more harm than good on these now. I'm going to, you know, stop and spend more time with irrigation, do less harm to the tooth. Again, from yesterday or today, this one was from they're all running together now, I believe is yesterday, finished this one yesterday. Patient came in here and was having some discomfort. Cleaned the case up, we did a little gingivectomy, and we'll get into that on a couple of the down the road webinars here. But access, as soon as we accessed, I put a little isolation barrier here. And after we did that, we came in with a tip number 3, water only, and then determined our length. Came in here, you can see these were pretty long, thin roots here. So we did these to 1704. We got anastomosis there between the MB and ML, gray length control. And then we had a nice build up there from the gingivectomy that allowed us to easily restore the case. Again, just very predictable, practical treatment. Called this patient today. Again, he was doing great. And this case was from yesterday as well. We recorded this case here. And so I'll show you a little video. That way we can kind of see a stepwise approach of exactly how we're doing this. So we've got the pre-op here. This is how it presented here. We can see the decay. Next image is after caries removal, and this is access into the chamber. And so what we can see here is that liquefactive necrosis going on. And then again, what I did, put a little barrier around the tooth there. Cool dam is what I used, a little cool dam on the tooth there. And that's what we have here. And so this is the video here. So cool dam's on the tooth. Now I'm going to employ the number 3 tip into the chamber here. And this is just water only. And so this is going to go on here for about a minute. We're just going to stay in there and And what I want you to see here, let me pause this real quick. Back this up. So I'm going to go slow-mo here, and we talked about debris coming up. Watch real close right here where the high-speed evac is, and you're going to see a big chunk of tissue just come floating up and being sucked up into there. And this is what it does. You'll see this all the time in the scope, just stuff flying up. Boom. Did you see it? I'm going to do a replay here. It's right here. Big chunk of tissue. Just came up. And so I'm not really, it's just in chamber. I'm not touching the canal walls. I'm not going inside the canals or anything. Just on the top. You just kind of hold it still. You can kind of angle it if there's a couple canals, full deep canal there. And so that's the first minute. First thing we do after access, build a little isolation barrier there, and then we're going in there and running the laser there. And so what we have here now, move this out of my way so I can see. Again, this was a picture right after access, carries removal, liquefactive necrosis. This is only water only in here. And you can see how clean, I mean, this already is. We can see that isthmus going on between there. We see down the canals, both the canals. I haven't done any instrumentation at all yet. That's only from the laser going on. Okay, so at this point now, what I'm going to do is I'm going to go in there, hand files, I'm going to determine working length, and then I'm going to go in and run a 1704 down to length if I'm able to. And so we've done that. We've instrumented. Now I'm going to come in here. I've done one instrument, so I've done the 1704. So I'm just going to come in with water only on this one. So I've got water only going on. I'm going down, and you can see I'm gradually pulling out. So you can do this in between instruments with water, or you can do it with hypochlorite or EDTA, whatever your preference is. Again, you're the clinician, you're in control. It's up to you kind of how you want to handle that. So this is water. And then I went back and I did a 2006 on this case. And then now I'm coming in with hypochlorite. And so in this case, we did not do the continuous flow where my irrigant does it. Too tight an access. And so I just irrigated there with hypochlorite. And what I want you to see in this is the protocol here. And so you're going to see that I'm going to go down to mid-root. This is number 1 tip, 17 millimeters. I'm going to go down, passive, activate on the way out, and then watch what I do on the way out. Once we get right out of the orifice, you're going to hold it for about 10 seconds right there, and you're just going to activate it. And I'm just holding it, activating it. 10, 15 seconds. Okay, then I'm going to jump over to the other canal. Same thing. I'm down, I'm slowly withdrawing, I'm activating. That's round 1. Hypo, again, coming in round 2. Looking great, okay? Same thing. Activating on the way out. You can see that solution kind of starting to pop out there. So you'll see that solution just pop out of it. Once you see it's just getting low, then you need to stop and you need to refill the canals and the access with irrigation there. This is hypochlorite again. I'm going back in. You can see I dropped it in, passive. If you feel that fiber line on the way in, pull back a millimeter and then activate. One more time. So this is the 4th pass with hypochlorite on this one. You can see it's shooting out the opposite canal that I'm in. So if I'm in the buckle, rinse out here, then we'll start putting the fillers, okay? Shoot out the buckle. So now what I'm coming, I just left the number 1 tip on. And what I'm doing now is I went back and I'm at 1.5 watts, 20 hertz. I'm just staying in the orifice now. And this is just a final rinse with water. 1 minute, flush out with water. I like to do this at the very end. You don't have to, I suppose, but I think it does a good job of just kind of really flushing everything out at the end, removing everything from it. My assistant is blowing my mirror off. Does a great job keeping everything dry so I can see. I guess you don't really have to see, just kind of hold it there, but so on this step here now, we're going on to the operation. And what we have here, let me show you, is so the image on the left is after a little instrumentation and then going down inside the canals with the number 1 tip. Image on the right was right after we had accessed. And so you can see how the irrigation has really cleaned out that isthmus, has kind of removed some of that calcification that was in there, opened that up. We used conservative files. There was no files in this. That was all from active irrigation, just kind of flushing all the debris that was harbored in that little isthmus between the two. So that goes on, on these lower molars. You saw that isthmus we had earlier that I just showed from yesterday. So it's really cleaning those out, doing a great job of that. Here's the case here, and we did a little gingivectomy on the distal side of that as well. Again, we're going to get into that in other series down the road, but case here, see a couple lateral canals here on both sides, a couple posts in there, case restored, ready to go back for posts. So again, these are all just recent. Now I showed this case here. I treated this case about a year ago, and IP on number 31, and had a little crack on there. We treated, and he just came in. Well, let's talk about the treatment first. This was a deep split in there, and I went in here and I couldn't see it until I got my number 1 fiber down in there, lazed, and then I could finally see the split off that allowed me to come in here and obturate that case. So this image here is a 1-year follow-up. I just saw him this week. He called and said he's in a lot of pain on that tooth, and so I was thinking, oh, it's cracked, and but that's not what was going on. Took a CT and noticed this going on the CT. I'm sure everyone has seen this in their practice at some point in time. This guy's got really thick, large tori going on, and so he had a little bony sequestrum going on there, and this is what it looked like clinically. So you can see all that swollen. There was actually more in the area of number 30 than 31. So if we go back, we can kind of see this is 30 right here, kind of where that was, and all that swelling. So what I did on this, I actually used the 500 micron fiber, the perio settings, which is 1.5 watts, 30 hertz, and 50 water, 20 air. Came in here, lasered this area through the, there's some little sinus tracts in there. I come down here and in the sides, down the sulcus in the sides, lasered that area. Then I went in there with some cotton pliers, took out a huge chunk of necrotic bone, a little bony sequestrum that was there. Called him today. He said he's doing much better. It's funny, you'll see these patients from time to time. I'll get a handful of these a year. They'll come in, they'll think it's a toothache. Sometimes a root canal has already been done. You look in there and they have that sequestrum going on. It's like a huge splinter. You take that thing out, it's almost immediate relief. But so we lasered that area real good. And then I was able to pull that out. And then I went back in there, relaced it with that. Again, these are some advanced settings we're going to get into later on. But then went back in there, just did a little detoxification kind of all around that area, just to kind of help stimulate healing. The soft tissue results that you see after the laser, it's pretty phenomenal. Can't really explain it, but anyway, that was a pretty cool case. This was my last case of the day today, so finished this a little after 5 Central Time here. She was coming in, and a little crack on the backside. We kind of talked pros and cons, and wanted to look in it and make sure, and I didn't see it going down the side of the canal, so I felt good about this. But interesting thing on this is number 20. So I actually saw this patient in 2015, and for this extensive resorption, and this was actually today. So I was pretty amazed that it's been 8 years, and that's the longest recall I've seen on advanced resorption like this. But anyway, interesting on that. So we got CT here. This tooth was necrotic. We can see the proximity to the inferior alveolar canal here, nerve bundle. Root apices kind of coming out there. Again, I have no issues using the laser on these cases at all. Zero. We'll go in here, access the case, little cool dam going on. As soon as we access, cleaned up the decay, cool dam, disinfected inside here. went through all the steps for necrotic teeth. This was I ran a 3006 down here. So again, I've been on both sides of the spectrum with very, very minimal instrumentation. I'm settling in the middle here. Again, that root form appropriate. And I think this is very root form appropriate instrumentation here. Side view, we can see all the, just this anastomosis of anatomy that's going on here, this webbing actually between the distal and the mesials going on there. Again, I did this case at the end of the day, and just hot off the press here, so to speak. So, these are not, cherry picked, hand picked cases. Did this case today as well and went ahead and recorded that. And this guy came in, we could see tissue overgrown here, did a little gingivectomy, cleaned the decay, sound seal barrier went down, and then we went through the necrotic protocol here. So let's check it out and watch a little video. So, and actually, I would say this tooth actually had vital tissue in it, and you're going to see here, I said necrotic here, but it actually had vital tissue, and a little necrotic, just in the early stages, right in this area. It kind of looked, like it was dying off, but once we got down here, it was definitely had vital tissue going on. And so this was right after access. You can see little heme there in the distal canal. And so I show this here. I want to show you my, just real quickly, my protocol here for how we do this efficiently. So I take all stops off my files. I use the lines on files. I don't sit there and play around with the stops, use those. And then I don't sit there and pass syringes back and forth for instrumentation anymore. Many of you have already seen this if you've been to one of my lectures before. But what we do is we put the file in here. Right? I know my link. And then my assistant is rinsing off the debris from the flute as we come. And then I'm just going in and out of each canal there. Very efficient again. I know the measurements. I'm looking at the lines on the file. And that's actually a rinse that we rinse with Dawkins solution. So we have a little self-contained bottle on the assistant side filled with Dawkins solution every day. And that's what we use to rinse with. So that's how we do. Again, it was vital. So I didn't come right in with laser first. I went in there. If you come with a laser first on vital, you risk making that collagenous plug and blocking yourself out. So you want to get some of that pulp tissue out first. So we've done that, instrumented. Open the canal. So now we have our number 1 tip on and coming in here, activating, and I'm holding just like I did. So this is my protocol. Go down the canal. There were 2 distals. Go down, slowly withdrawing, and then we're holding. Open real big for me. What I want you to see here, you'll see it on the post-op film, but it actually had a little resorptive defect here. You're going to see some heme coming up from that resorptive defect. So this is the first pass in there. Notice that heme coming up there. Okay, so we're going back with some hypochlorite now. Okay, now we're going back in that canal. We had the first, this is our second pass. That first pass cleared that tissue that was in there away. No heme now. Activating on the way out and holding. Now you can see these mesials, they're smaller canals, so I'm not going down as far on that. I'm not going around the curve. I'm going down to where it's passive, I'm withdrawing, and then I'm holding. So maybe mid-root is around the curve, then I'm not going mid-root because I'm not going around that curve with this. Now we're going down the distals here. And then, we like to say, hey, 3 times, but that's just kind of the bare minimum. You're in control. If you need to go 6 times, different passes, do that. A lot of times though, if I'm doing a continuous flow, we fill a 10 cc syringe and we go through like 2 of those. And I mean, that's a ton of hypochlorite going in there. All right, so we've done the disinfection here. Now we're coming in. And what's next? It's our final rinse with water. So we're coming in, we're just activating here. Just holding at the orifice level. I may gently go in there just a little, but not much. On the measles, I'm just staying at the orifice there. So there's a little timer on the side of the EdgePRO. If you have one, you're aware of it. It just does a countdown for you. So, you just go through there and peek over, and that'll tell you where you're at there. And this was the case again. This was off the little gingivectomy. You can see how clean the restorative is. Minimal instrumentation on the mesials. We did 1704, and then we did 2006s on the distals, constant taper. We did the V taper. He treated files there. You can see the kind of mid-mesial canal that split off coming off here. There was zero instrumentation of that. That's all irrigation. Here is there was a little resorptive defect right up here. You can see how that kind of is a little more bulbous there in the canal here. So that's what's going on there. Here's the CT. Again, you can see that little resorptive defect going on. Distal canals, very canal terminus there. Same with the mesials, and we see that little branch off there on the axial slice coming off the MB canal here. We can see that isthmus being filled there, and then coming out where we see a little widening going on here. That's exactly where, we see that here too. It's exactly where that sealer's tracking to. And then the coronal slice as well going on there. So, that's in short, kind of a quick protocol, my protocol there and how we handle it. Cases, I think it's a good way to get started on there. And again, ask yourself the why. Why do you want to incorporate one? And then once you get it, kind of make yourself sit down and use it every case from get-go. So lectures 2 and 3 that we have coming up here. Dr. Anderson, I'm sure most of you know Dr. Anderson, awesome clinician. Tune into that one. It's going to be great with him. And Dr. Butler, I met him recently. Same thing. This guy, awesome young clinician, up and comer. He's fantastic guy. So they'll show some cases, kind of their techniques. Again, everyone has a little twist on how they do it. Then we'll talk about some adjunctive uses. I'm going to talk a little bit about dual wavelength at that point in time. We're going to talk about kind of benefits of adding the EdgePRO and maybe touch a little bit on the ROI and how that can have a positive impact on your practice. And we'll do a Q&A as well. And so you can ask any of us any questions, troubleshoot any issues going on there. It should be a good time. And again, at this point in time, I will turn it back over to Chris. And again, I thank you all for your attendance. And if there's any questions too, you're welcome to email me, and we can go that way, or send me a text or something.
Thank you very much, Dr. Maupin, for that excellent presentation. Yes, you can imagine we have a host of questions for you. So if you don't mind, I'm going to field some of these and see if we can get the majority of these answered. If we don't get them all answered, I will present them to Dr. Maupin, and we'll make sure that we get them addressed. As everyone knows, this recording is taped. I'll find a way to see if we can get these questions all answered and collated as well. But first one here, I'm wondering if the laser can help with debriding sometimes difficult to negotiate canals like MB2 and middle mesial canals. I have trouble sometimes cleaning challenging anatomy. Can I rely on this technology to predictably clean?
Yeah, absolutely. And I've got, I've shown case after case. I think I have one that's just really focused on MB2 canals of cases where, like that one I showed earlier, wasn't able to locate it. That was MB1 actually, but MB2s that I wasn't able to locate, spent a lot of time, and we'll address that kind of on session 2 on how to do that. And that's where you really want to focus with that number 1 tip right in that MB orifice. And I think it's imperative that you have cone beams on these before going in. That's where, if if I have a case with MB2 and it looks completely separate all the way down and I haven't located, then that's the case I'm probably not going to do in a single visit based on that. Now, if it looks like it joins based on that CT and I've troughed a little bit, haven't found anything, I'm going to spend a lot of time activating around that MB, maybe in the MB just a little bit, sending that energy in there. And I can't tell you how many times I've done that, and the cases have, I mean, it's retrofilled the MB2 canal there. So, you know, is it 100%? I don't know anything that is. What's the saying, except death and taxes is the only thing that's a certainty. I mean, once you get comfortable with it and employ it and, you know, embrace it, then that's when you'll start seeing the results. If it's just, again, like we said, you know, if it's just the what, and it's just something that you kind of, you know, take in, those are the people that struggle with it. But if you really embrace the technology and the why, then you're going to see the results that you want.
Great, thank you. Another one here. Why did you gravitate to the laser rather than GenaWave? Is the level of biofilm removal / tissue dissolution comparable between the two?
You know, I've done a few bench tops and they seem to be comparable. I gravitated towards the laser for my number one was safety. And, you know, I felt more comfortable utilizing the laser for that. I've used them both. And for me, that was paramount. Number two is ease of use. It's just, there's zero disruption to my clinical flow. Just bring it in, I go with it. I'm not, you know, having a refrigerator behind me with chilled saline. It just didn't disrupt my flow to the practice. It's multifunctional was another key component, meaning I can use it for, you know, endoperio defects, sinus tracts, canal disinfection. So that was another key thing for me. You know, the cost of the tips, I think, is something to factor in as well. I mean, at some point, you know, you have to pay attention to that. And anyone who's saying, you know, not to, I don't think they're being fully honest on that. So I think those are some of the main reasons. But again, my top one, safety, and then just ease of use.
Yeah. Does your technique vary with C-shaped or severely curved canals to avoid the potential for ledging?
You know, for C-shaped, I'm not going to go right down the isthmus there where it's super thin. I'm going to stay up the top there. But I mean, you can see how well I mean, you have access to the fins there. And you can see on some of these cases where, I mean, the energy is quite a ways away from it, and it's cleaning these fins, these isthmuses out. So C-shape doesn't really vary. The curved canals, like I talked about, I will not take the fiber past a curved canal, and you want to stay above the curve. So activate above the curve and don't go around it, and you won't have any issues.
What are you using for sealer? Are you burning down and backfilling, or sealing and compressing at the orifice?
I use Kerr Sealer and Kerr EWT. I've used it from day one. It's got a long track record, and I like that I can control the viscosity of it. I can mix it runny, I can mix it thick. So I like that. I like some of the properties in it. The silver in there, antibacterial. And then I do I call it a modified down pack. And so I do go in there and down pack a little bit, and then I'll backfill some. Am I anywhere near the quote, the shielder that we talked about, 3 to 4 millimeters? No. But we do a modified down pack.
Great. And then when you're talking about holding the tip at the orifice for a period of time after withdrawal, if some users are seeing that maybe the mechanism of action isn't working as well, is there an actual landmark where you would want to stop and hover? Is it, you know, still within the canal slightly, or is there some kind of landmark that you rely on?
You know, so I don't like to be inside the canals and holding the fiber still.
Okay.
You know, that's where you can kind of ledge. So if I'm holding it still, majority of the time I am above the canal orifice. If you're not seeing the mechanism of action, the, irrigation bubbles basically going on, then something's wrong. Your tip, you need to check your tip. Maybe you clanked it off hit the wall or something like that. Change tips or something, not pushed in all the way.
Yeah.
But I mean, you should be seeing activation going on, and stay above the orifice. If you're not moving it up, out, you don't want to be in the canals.
Yeah, we've seen some of that if tips are reused, right? They're single-use tips, and that the efficacy can be degraded as well from that. Let me see, one other question. What do you do when the patient complains about discomfort when you're activating the solutions? Most of the time with sodium hypochlorite.
Yeah, so I mean that's very rare, but I've had it on occasion, like even with water. And I think a lot of the time, it's if you turn the power down, that goes away. So what I've seen that on is these severe AP cases. You lightly tap the tooth, and so I think a lot of times it's just the vibration from the laser energy stimulating the PDL going on. So turn the power setting down first is the first thing I recommend.
Okay.
But I've been using the laser since 2018, and I have not had any, incidences with it.
And you are using EDTA, right?
I use EDTA, I use full strength hypochlorite, I use EDTA and water.
Okay, great. Just a couple other questions here. Are you using any diluted sodium hypochlorite or concentrations straight out of the bottle?
Yeah, I use straight out of the bottle. Like I showed when I was instrumenting, I have my assistant has Dawkins solution on the back wall. And so let's say on a young 10-year-old or something, traumatized, 8, 9, open apex, then I'll use that Dawkins solution. They just kind of sprayed in the tooth where I may use water only. And that's also a good indication to turn the air and water off, dry everything out, and you can do dry mode, which there's some research around that as well, using the dry mode. In a straight canal, curved canals, you can't do that, but a straight canal, you can irradiate the walls. And that the chromophore there is seeking out water. So it's seeking out the cell membrane, the water in the cell membranes, and causing lysis of the bacteria in the cell wall. And they can penetrate up to about 1 millimeter into the dentin.
Yeah, great. And then any insights on how you might stop apical bleeding should occur?
What I've noticed, so when I was really instrumenting small, especially on vital cases, I would see that a little more. And when I started going a little larger, a 20 V taper or something like that, I mean, that seems to have taken a lot of it. So I think a lot of it is we're leaving little pulp tissue apical. Or the other thing is that the apical pulp stump may be there. So if you'll take a 15 file, put a bend on it, take it out the end and twist it, separate that little pulp stump. That'll do the trick too. It's been my experience. If it's one other little trick that someone else taught me, I was teaching a course, hands-on laser course, and they said if there's just bleeding a little bit, you spray, and I've been using it, works pretty well. Spray a paper point with some cold spray and stick that in the canal. That seems to work pretty well too.
Great. And then any specific techniques for working with calcified canals?
That's where I'll alternate back and forth. I'll 6, 8, 10 hand files short, and file with the 6, bring in the laser, file 8, laser, 10, and I'm just constantly going back and forth, getting a little further down, lasering, getting a little further down, makes it easier. Kind of going back and forth. That's kind of once you get the starting point though. Any of these, if you're asking it to find the canal for you, to start it for you, I mean, occasionally if you're right above it, it'll erode that top layer, and I've had that happen where I, like an anterior that's been, I've gone in there and guided, down as far where I thought it should be, and then I was hitting nothing, and I put the laser in, and I was just right above it, and then the 10 dropped in. So I've done that, but most of the time it's just a toggle back and forth between hand instruments and the laser.
Great. Well, in the essence of time, I just want to be respectful. We got a majority of those questions answered. But again, Dr. Maupin, really appreciate your presentation. Very, very thoughtful. And as always, I always seem to learn something. I think that, just for the audience, yes, we encourage you, please, this will be a building series. We'll get deeper into technique and as well as some of the extending applications with EdgePRO. Dr. Maupin talked a little bit about gingivectomy and some limited soft tissue work that we're using with EdgePRO. We didn't really get into the physics of erbium chromium YSTG. That's something that we can address with you should you have interest. For those that don't have EdgePRO, our area sales manager can help you with some of that. I'm sure Dr. Maupin can answer some questions around that too. Many of you know that EdgePRO was born out of a partnership with BioLace, which has had lasers in dentistry for some time, especially the erbium chromium 2780 nanometer wavelength. And so the technology is, and the wavelength is exactly the same. The research that was born out in the early 2000s around that and specific to endodontics is exactly the same. What we've just done is packaged EdgePRO into a system that we feel is ideal for endodontics, and especially in the field of advanced cleaning and disinfection with some limited capability in soft tissue. So we'll talk a little bit about that as the series continues. We're also excited, as Dr. Maupin said, to have Dr. Craig Anderson from South Mississippi Endodontics in Biloxi, Mississippi, and Dr. Jacob Butler from Wichita Endodontics in Wichita, Kansas, join us for the ensuing webinars. Part 2, I remind everybody, will be on August the 17th from 7:30 to 9 p.m. Central Standard Time. So mark your calendars, and if you register, you'll get reminders of that. So hopefully that doesn't become too annoying, but certainly reminds you of when the next program will take place. And then part 3 will be on September 14th from 7:30 to 9. Both of those, again, will involve our faculty and our panel in addition to Dr. Maupin. So I think we'll wrap things up, but again, appreciate your time tonight, Charles. Very insightful, and appreciate everybody's attention and joining us this evening. Hope it was valuable for both folks that are already going down the pathway of using EdgePRO and building it into your work stream, as well as folks that are interested in the technology as we go forward. So thanks again, everybody. Have a wonderful evening. We'll talk to you soon.
Thanks, Chris.